Going to explore the question, is national interoperability finally a reality? Our panel today will be moderated by Dr. Greg Forzley. Dr. Forzley is a longtime central figure in Michigan's HIT efforts, having served as the chair of our HIT Commission from its inception until 2015. And Dr. Forzley currently not only sits on the MiHIN board, but also the board at Great Lakes Health Connect. Dr. Forzley?
Thanks, and I should add that I have recently retired from my role as the System Ambulatory Chief Medical Information Officer with Trinity Health. And you might say, why in the world is he here on a beautiful day like today? But it's because of the passion that I have around health information technology and health information exchange that I agreed to support this panel effort today. So thank you for that. Let me start by introducing our members of our panel. Right to my right is Scott Stuewe. He is the founder of Blue Water River Ventures, but has been a former director with Cerner Network. So he will be providing insights on CommonWell and some other activities in that area. He's a 25-year veteran of health information industry and is an expert on network creation and interoperability. Prior to his January departure from Cerner, he was leading the campaign effort to transform how health data is exchanged by fostering a vendor-led CommonWell Health Alliance from its inception. So he was involved from the very beginning of that effort. Within that, he worked to recruit vendors and health systems to participate, ultimately extending the alliances to reach 70% of the acute market. In December, CommonWell and CareQuality agreed to collaborate, and I'll speak more to that in just a minute. To his right is Dave Cassel, and Dave has worked for 19 years in healthcare IT, creating a national reputation as an expert in health information exchange. He's developed and launched health IT initiatives and applications throughout his career, constantly incorporating interoperability into all projects. He holds a Master's of Science in Economics from the University of Wisconsin and a Bachelor from the University of Delaware, and is applying that full force as the Director of CareQuality. And to the far right is Michael Matthews. He is current President and Board Chair of the Sequoia project, but he has 40 years of leadership experience in health IT and population health, and has been advocacy all along for vulnerable populations. His noteworthy accomplishments include his role as president and chair of the board of Sequoia Project, operating the entity for eHealth Exchange and CareQuality, while previously chairing the coordinating committee of eHealth Exchange. He was the CEO of Med Virginia when they first became an information exchange to join the first information exchange to join eHealth Exchange and the first HIE to interoperate within Virginia. He is the Chief Executive Officer of a provider-owned ACO and served as Principal Investigator for over 10 million. He is currently the Senior Engagement Director for the Cedar Bridge Group. So with that, I'd like to kind of go ahead and let them give further explanations about themselves. And there was an old-time movie that said, who are those guys? So we're going to start with that question. And maybe either Scott or Mike can start.
Good morning, everyone. It's really nice to be here with you and see such engagement across the board and interoperability across Michigan. And first of all, hats off to MiHIN for the remarkable progress that has been made. It's very gratifying to someone who's watched a lot of efforts over the years, and to see the kind of traction you're getting in Michigan is very, very impressive. I was struck by a couple of words that the Lieutenant Governor said, and it's around determination and perseverance. And if you're going to do this work very long, you have to have both of those qualities. I've also said you have to balance patience and impatience in this work, that if you're too impatient, you'll go absolutely nuts. And if you're too patient, nothing will get done. So with that, let me tell a little story about the beginnings of eHealth Exchange. In December 15th and 16th of 2008, there was an MiHIN forum, Nationwide Health Information Network forum, held in DC. And this was the first time that in live production systems, there was demonstrated in production, patient data could flow across the 9 health information exchanges that were participating in the trial implementation, and with the federal agencies of the VA and DOD and SSA. And on the second day, then Secretary of Health and Human Services, Michael Leavitt, was really struck by the importance of that event. And I can recall his words very vividly. He said, "On the way to all great things, there is a moment. There is a moment when the impossible becomes possible. Ladies and gentlemen, this is that moment, and the world will change forever." And it was a very inspiring moment for all the people who had worked so diligently to move through the prototypes, to move through the trial implementation. And I like to joke that I was so inspired by his comments that I blurted out, "We'll be in production on eHealth Exchange by the end of February," without telling my CIO that I had done that. But in seriousness, I got up with the deputy commissioner of SSA, and we shook hands and made an agreement and full commitment in front of this group that we would be in production, the first production on eHealth Exchange by the end of February. We worked literally around the clock from December 16th until February 28th at 11:45 p.m. on February 28th. The first live transaction went across on eHealth Exchange, and eHealth Exchange was born. From that time, eHealth Exchange has grown extraordinarily. It's now present in all 50 states. 65% of all U.S. hospitals are a participant, 50,000 medical groups, 47 state and regional HIEs, 8,300 pharmacies. The list goes on. And I will so a lot of foundation has been laid across 150 participants of eHealth Exchange. I'll provide just a little bit of definition of names and organizations because these are very often confused, and they have been changed over time. So eHealth Exchange was incubated and supported by ONC during the first 4 years. I think we all know that history. It was during that time the DURSA, the Data Use and Reciprocal Support Agreement, was created as a foundational trust document. 4 years ago, the operational responsibility for eHealth Exchange transitioned to a not-for-profit corporation known as the Sequoia Project. And it basically represents a private organization with a public mission, and that's to relieve the burden of government for that aspect of operations and interoperability. So Sequoia is the operating entity of eHealth Exchange under the policy and governance of the Coordinating Committee of eHealth Exchange. What Dave will be speaking to is another operational responsibility for the Sequoia project called CareQuality, and I won't go into that and steal Dave's thunder. So there are basically two important interoperability initiatives of the Sequoia project. Thank you.
Thank you. Scott, you want to fill us in?
Sure. It may be confusing skipping over Dave because...
Well, I want to come back. That'll hopefully bring it together.
All right, okay. So, as Greg indicated, I was present kind of at the birth of CommonWell. CommonWell is something I'm intensely passionate about as well. This general notion of exchange is intensely important. I'm acquainted with MiHIN by the fact that they are actually a CommonWell member among the 64 CommonWell members. So CommonWell, if you're not aware, is a 501c6. It's a trade association that was created basically 4.5 some years ago. At HIMSS 2013 it was announced. And it really arose around a specific problem that I think remains unsolved, but one that we need to continue to work on, and that's identity. So identity was really the upshot. It really, it arose specifically because of, of things that our industry was hearing from the ONC at the time, that basically, there's not going to be a national identifier, get over it, was basically what we heard. And so a couple of key gentlemen who worked on the direct protocol together from Cerner, so a colleague of mine, Dr. David McCauley, and another gentleman from Relay Health named Aaron Malik. They worked together. I imagine that they went to dinner and said, what are we going to do about this? Because this was at the point when direct was sort of getting firmed up and was kind of had its had its inclusion in ONC requirements. But there was no answer for direct exchange that we felt like was going to solve the real problem, which is identity. So they, at dinner, cooked up this notion that if you're going to do this, you're going to need to have some shared infrastructure. In order to pay for that infrastructure, I mean, someone's going to have to buy the servers and do all that work. So what about if we get a consortium of vendors to mutually agree to fund that effort? So that's kind of how CommonWell came about, and one of the fundamental differences about CommonWell from the other initiatives is CommonWell is an opportunity for the set of vendors that are our members to jointly fund infrastructure that's required to solve problems that arguably maybe should only be solved once nationwide. So that's the core capability. In terms of the personal aspects of this, I think we all have personal experiences that suggest that interoperability is not fixed, that identity is a big part of it. False negatives are the bane of our current model. There's tremendous ability to actually exchange, not just within CommonWell, but within CareQuality, and then after this announcement and after that bridge is made, between CareQuality and CommonWell, which is awesome. And there are vendors who participate in all three organizations separately, the Yield Exchange, CommonWell, and CareQuality. So query-based exchange is happening, but identity remains an issue. So I'm tremendously excited about the opportunities that the collaboration between these organizations represents, and excited to be here.
Thank you. Yep. Well, speaking of that collaboration and cooperation, that's the partnership aspect that we were talking about. So Dave, you want to jump in with explanation about CareQuality?
Yeah, absolutely. Thank you. So building on what Michael and Scott have shared here, the idea with CareQuality was really to recognize that these data sharing networks and programs and services were out there. They're doing great work that we didn't want to disrupt, but at the same time, we saw that there was still a need to go a little bit further, take the one step where for some key use cases that all of these different groups shared, we needed to have a framework, a trust framework, along with some other elements that allowed specifically for exchange activities to occur between and among other existing data sharing networks and programs. And we see it a little bit like what the telecom industry has been able to do with cell phone networks, where as a consumer, you still sign up with a particular service provider or carrier, but then you just make phone calls, and you don't think about who your carrier is relative to the people you're calling. You don't have to have 10 different cell phones in your pocket, because the telecom industry has a framework behind the scenes that as consumers we're largely ignorant of, but it exists, that allows them to have that calling and interoperability, if you will, occur between the various carriers. Now, the analogy breaks down if you try to take it too far, but that's the general idea behind CareQuality, is to provide a structure that will allow this to happen in health IT. So we have organizations that we call implementers, who are these various data sharing networks, programs, whether those are health information networks. MiHIN has actually recently signed on to be a CareQuality implementer. CommonWell, as part of this collaboration agreement, which has some broader elements beyond this, but as part of the collaboration, CommonWell has signed on to be a CareQuality implementer as well for the purposes of exchanging some query-based document exchange activities, basically, is what is underway right now. So all of these various data sharing networks and programs can come together under CareQuality, continue to pursue other value, other exchange activities, things that are maybe more specific to their particular community, whether that be a geographically based community, like is the case with MiHIN, or a national community, as is the case with CommonWell, or something in between. But they can all continue to pursue those pieces of value, but come together for those core use cases that they have in common.
Great, thank you. Well, we have prepared a list of questions that we'll try to work our way through. Many of them tend to coordinate and bring some of the comments that have already been made together, so let me start with that. So as we've all heard recently, A lot of movement has been made in this direction, and Tim reminded me yesterday that when he and I talked a few years ago, I said it was going to take 15 years, and he was mad at me about that. But it turned out that we're getting close to that 15-year timeline that we were talking about. So we are getting there slowly, but I'm seeing the momentum increasing. So what national barriers still remain on an interoperability perspective, and how do we make sure that we leverage what's already there? Mike?
Maybe I'll take a first crack at it. When we think about things at a national level, part of what you'll hear, I think, from the three of us is a lot of the interstate highway has been laid. There's not enough traffic on that highway. You know, we don't have enough on-ramps. We don't have enough vehicles of the right type. So I think, well, okay, so what's the problem with that? If you think about need and supply and demand, everyone in this room, I'm sure, can articulate plus or minus 10% what the need for interoperability is, whether it's from a consumer perspective, provider, efficiency, and so forth. The supply is basically being laid out there, so the capabilities, and when this happens, you know, that supply of interoperability, ubiquity is out there. I think the key barrier that still faces us is demand. There's not a demand on the provider side for a standard of care that involves interoperability on every single patient interaction. And until we achieve that kind of demand that says the interoperability and data sharing is a standard of care in this country, I think it's always going to be viewed as something optional to the side if there's time, if the workflow barriers go down, et cetera, et cetera. So I would say that's one big thing. I think we also recognize exchange of information has to go beyond the physician and hospital. And I think of the long-term post-acute care, I think of behavioral health, I think of community organizations that are so important in value-based care and population health initiatives. They, by and large, been left out of the game so far, and we have to figure out mechanisms to get them back in.
Want to add to that?
So I totally agree, and I think the demand, I think, is most fundamentally, so as Genevieve was pointing out, I think the demand mostly is affected by the payment model. So as long as people are disincented to know about the stress test result that they could just reorder and be reimbursed for when the patient shows up in the ED. And I met with it was actually an Ascension physician in Detroit who was describing the situation where he knows the patient has a stress test and he wants to get the stress test. Now, this is a case where he actually has the demand, but they're a little unusual as an organization. I mean, some organizations, I would think ED doctors probably all behave the same, which is that they all want that stress test. But does the office have the motivation based on the current business model to actually not order that test when it's a $2,700 revenue opportunity today in most cases? So now, as the thing shifts, it's a huge change, right? As we move to fee for value, it's going to totally change the way things work. So I believe that that's the case. So I think that's the big issue today is the motivations aren't yet, the incentives aren't yet aligned.
So that inherent altruistic nature is not yet overtaking the need for financial liability or responsibility?
I think in the ED, by doctors generally, the Hippocratic oath kicks in, but in the front office, it doesn't live up there.
Okay. Dave?
Yeah, I mean, I think I have some similar views. It may be temperate a little bit that you have to look at the big picture of what the various provider organizations are facing, and in the privacy of the boardroom, they are faced with decreasing revenue, increasing expenses, and when you look at where are we going to make our limited investments that we can make, am I going to put that towards new state-of-the-art diagnostic equipment, for example, that I can advertise and bring new patients in and drive new business? Or am I going to spend that on an interoperability connection where, quite frankly, it's not clear to me exactly what the ROI is. Maybe it's even negative, depending on the revenue model. So I think to be fair to the folks making those decisions, they're faced with a complicated challenge. And our role, that, as I see it, those of us here on the stage, and really most of us in this room probably, is to change the economics of that decision that they have to make it easier, provide greater value. Now, obviously, that's easy to say. And it's a long slog, and it's that 15-year process of actually doing that. And I think we are getting there. We're getting to the point where, as Michael was saying, people have their various metaphors. The pipe has been laid, the wires are laid down, the highways are built. Now it's a matter of saying, okay, what's actually driving over the highways? Does the content that we're able to share actually provide value? And that to me is sort of the next step. And I do prefer, just to my sunny disposition perhaps, I prefer to think of it as next steps as opposed to barriers. But really having the ability to provide value through the information that's being exchanged, paying much closer attention to that. Now that we've, I won't say solved, but we're certainly making a lot of good progress on the sort of the transport front. What are we transporting? That's the next step. And as soon as we can provide value there, I think then it becomes a virtuous cycle where it starts to enable more of these value-based contracts that will in fact drive incentives to further exchange activities.
Okay, thanks. So I've spent the last couple of years focused much more on population health and sharing of information of populations. But one of the thorns that continues to rise is the fact that, excuse me, it's not user-friendly from a workflow perspective in the way that we do things. And when you think about it from a person-centered perspective, that's where the meat of the interactions occurs, is at that level. So what do we need to do to get more into the workflow of the users? And the users base is expanded now from just providers and health systems now to consumers. So,
yeah, so having worked for a vendor, and I think Dave and I share this, we spent a lot of years working for, in the industry. And, the industry is incented, each individual vendor is incented to make their workflow as easy to use as possible, because that's what makes the world go round. The challenge is with interoperability is it's a bit of a moving target. We're going to have a huge change here really in a relatively short period of time, and some people have already experienced it. Right now, that people are barking about not having any data at all. They can't get any data, so why bother looking? If I look and I don't find anything, I'll never go back. That is the complaint du jour. Well, the complaint tomorrow is going to be, this is so much crap, I don't know what it is I'm looking at. So the complexity of data exchange is changing, and it's changing as we sit here. I mean, like, by the time the 2015 edition comes out and next year happens and people are doing CommonWell and CareQuality data exchange, there's going to be ugliness that people haven't yet wrapped their head around. And I think the vendors are thinking about it hard. I mean, I know from Cerner's point of view, they certainly are. On Friday, there will be a gentleman here, and he can describe what it is that they're doing. I'm not with them anymore, so I won't speak for them. But what I can tell you what vendors must do is they must figure out how to solve this problem in a way that doesn't assume that the data itself is going to get any better, because it's not. The data is going to continue to be variable. And so the workflows of the actual systems are going to have to be pretty smart. They're going to have to be able to do deduplication, which I can never say, and they're going to need to be able to present the data that's of interest based on what the user thinks is interesting. And those are hard problems to solve, but I mean, the HR business has solved hard problems before, and they're incented to do so just because they're in a competitive market.
I would agree with that, and I laughed when Scott talked about the moving target, because I had exactly the same thought, that if only we could just get these systems to just sit still and let us work on them for 5 years and develop interoperability, we'd be in great shape, right? But they're always advancing. They're always doing all the vendors always doing other development, adding new workflows, adding new functionality as the market demands. And as we just discussed, sometimes that demand is stronger than the demand for interoperability, and so as soon as you develop one piece within your application that supports interoperability, now all of a sudden you look back and instead of patting yourself on the back, you say, oh, wait a second, now I have 20 other modules whose data I need to integrate into this interoperability feature. And so and we're never going to solve that problem, if you will. That's always going to be there, and I think it's a good thing overall. We just need to recognize that there's always going to be a little bit of a gap, I think, behind the cutting edge functionality that's developed in various systems and the ability to exchange the data within those features. And that's something we're probably just going to have to accommodate in our expectations.
Greg, I would only add that I was struck again by a comment from the Lieutenant Governor. I mean, he nailed it. He said, the physician should be able to open up my chart in the EHR, and there's all the data the physician needs to take care of me. And that's what we're talking about. And for somebody outside the field, you know, we always think we're so bright here, nobody can possibly understand our world. He made it very simple and compelling.
Oh, that's perfect, because one of the things I was going to ask you all is how will provider expectations and demands impact what happens going forward in the future developments? You've talked about it a little bit.
Well, I mean, I think it's going to be huge. And when I talked about how we actually derive greater value and have better content that we're exchanging, providers are essential to that effort. You know, we can sit up here and pontificate, but ultimately, if we really want to drive improvement, we need to get the feedback. So we need the early adopters, who we have now, and they're not even necessarily early adopters anymore. They're mid-level adopters, I'd say, timing-wise. Getting their feedback, understanding what the pain points are. I think Scott was exactly right. The more we start to roll out the ability to connect at a nationwide level, the more it starts to uncover some of the dark underbelly, if you will, of what's actually being exchanged. And that's fine. That's part of the growth process. But the feedback of the providers who are exchanging now is going to be absolutely essential in driving the value that will then get more and more of their colleagues in a position where they see value in joining.
So how do we get in front of that? Because feedback usually is the result of an end product, which somebody thinks that they've finished. And now you get people feeding back saying, well, that doesn't work in my workflow, or that doesn't work in this area. How do we make a change to that and make sure that everybody's involved?
Yeah, I mean, there's obviously a balance that you strike there, and you don't go to market with something that is just completely untested and untried. But you're also always going to have the case where no matter what you try to do in the lab or what you try to do in feedback sessions at user group meetings and this sort of thing, the real world is always going to throw surprises up at you, and there's no substitute for getting feedback from real life to resolving those things.
Okay.
I think one benefit of had this conversation with a colleague last evening. One benefit of having a baseline of requirements around EHR development, so that the usefulness of having meaningful use as a baseline. I mean, I don't think all of the, I don't speak for a vendor anymore, but as an onlooker at this point, I guess I can say, I think it's had the benefit of at least having a set of things that we're all agreeing is an EHR, which makes it, I think, easier for people to then evaluate what one EHR does versus another. So it's I think easier to in that environment, it has become easier for the vendors to get the feedback that they need because they're measuring against a baseline, a support expectation that they would provide exactly at least these minimum requirements as required by the ONC's 2015 edition. So I think that's a huge change in the way things have worked, and it has, to my way of thinking, watching this from the inside a vendor, I felt like it had the impact of sharpening the focus on what it is the users actually needed, because you had to do at least this minimum, and so you didn't argue about a lot of the roadmap. It was already kind of laid out. So you were worrying about some things around the edge that you could say, can we get agreement about how this should work? So I think it gets easier. I think the next couple of years are going to be interesting to see if the new workflows that are required for incorporation of data that are a requirement of the 2015 edition, if the workflows are usable. Because The first run of the workflows for incorporation as a part of stage 1 were not. I mean, as an observation, because the bar was so low, you only had to do, you know, the expectation wasn't very high. So,
I think if we go back to some of Genevieve's comments about how do we change the basic economic drivers and increase the need and demand and rewards and incentives for interoperability, I think that's a necessary component. To me, there's still a lot of work to be done when we distinguish data sharing that needs to occur at point of care. That's not where a lot of the systems change is driving us. It's not that necessarily and specifically at the point of care. It's for population panel management. And so, you know, how are we doing overall with the panel of patients? And to be able to fully understand that requires quality data and clinical data and payment data coming in from various sources and so forth. And yet, can that inform a point of care? Absolutely. But the capabilities of any EHR platform to do this work over here, to incentivize the work at the point of care, that's why I'm suggesting, you know, I think there's good progress, but I still think there's a long way to go on that front.
Yeah, I would agree with that. And I think the challenge is that this all becomes additive as opposed to one replaces something that existed before. And speaking of additive, you know, we have the new dynamic of the consumer involved now. So how would you see any issues or barriers that potentially exist related to consumer data exchange?
Well, I mean, the big challenge with consumer, again, is demand. I mean, most patients, you know, aren't yet engaged certainly in the exchange of their data. Even if you make it easier, the question of whether or not they will become engaged is an open one. You know, if I can make the application really, really easy to use and really, really valuable for the patient, then I think I can get the patient engaged. But if it's kind of work for the patient that, you know, that doesn't solve any problems. So, for example, if the patient were able to get access to all the data from their external sources, annotated in the way some of the folks have described, and then provide that to their provider saying, okay, here are the things I agree with, here are the things that I've changed. If I would be able to do that and also be able to track back the provenance of each individual element and know that the patient has changed this element, I mean, that's an important element of this whole idea. But if that were a part of it, then actually the driver of that is the patient not wanting to fill out the clipboard again. So if I could actually replace the clipboard with an interactive application to get the patient engaged, that would be a huge, huge jump. I think the EHRs are trying to solve that problem as a part of what they're doing, I think some better than others. I think ideally you'd do something where the patient could curate that process once and allow that connection to be made lots of places. I think that's the kind of thing that a CommonWell can provide an opportunity to develop that use case around how a patient can be engaged in that bushing between the PHR and the EHR.
If I could relate a personal example of that, my dad had a cardiac event 3 years ago, and my mom, 89 now, 86 then, she became his walking, talking personal health record encyclopedia. I mean, on demand, she could go to any of the Kelly's statistic of the 14 providers. I think my dad probably had 13. On demand, she could recite every medication, every procedure, dates, times, everything that happened with my dad. My two brothers and I, on the other hand, we couldn't remember any of that. And so we're keeping, you know, handwritten notes. Every time Mom would say something, you know, we'd write it down. We'd pass the notebook on to the next brother whose shift it was and that sort of thing. So that one struck me, wouldn't it be nice if, and I know the tools are out there, but, you know, getting that data populated across multiple health systems from a PCP in rural North Carolina, you know, it wasn't complete. On the other side of it, my dad had a pacemaker put in. And they said, okay, it's Bluetooth enabled. My dad's pretty savvy electronically, and they said, you need to always carry this communication device with you. And if there's ever a problem, it'll Bluetooth over to the communication device, go up to the cloud, come down to the vendor out in California, and they'll let your provider know. It sounds great. Who the heck knows if that stuff really works? Well, one day, his cardiologist in Charlotte gave a call and said, I think you had a little AFib last night. Why don't you come in? Nothing major, but come on in. It was like, this stuff really works. I was very impressed. You know, I've been in this business for a long, long time. It brought it home to me.
Yeah, and I think I would agree with everything that my colleagues have said here. The one thing that I would add is that, especially as we look ahead beyond what I'll call simple patient engagement in their health, and specifically in health information exchange, the work that we're doing to enable provider to provider and provider to payer and all these other operational components, that translates as well into opening up some opportunities for patients to participate in a way that I think is a little friendlier for the mainstream consumer, who doesn't necessarily want to be heavily engaged, doesn't want to download all their records and bring them together and annotate them. I don't necessarily want to do that. But if I could walk into a clinic that was new to me and have a little alert pop up on my phone that said, oh, hey, it looks like you're at the Peaceful Valley Clinic. Would you like to add this to my locations? And have that then be actually connected to an operational way of having my providers behind the scenes exchange records for me that I could sort of manage from a consent standpoint. That to me would be brilliant, and it's just one example of the sorts of things that having this exchange infrastructure will potentially allow going forward.
Yeah, and just to put a plug in for MiHIN, who thinks, I think, pretty deeply about these kinds of workflows. MiHIN's grappling with the identity problem, associating the identity problem with basically creating an opportunity for the patient to manage their own care relationships, which is actually very similar to CommonWell's model, where there's an opportunity for the user on behalf of the patient to control it, or the patient themselves to say, yes, I was at this place. So if what they do after they do that effort to say, yes, I've been here, or yes, this is my doctor, they then are able to get access to all their records and not have their clipboard filled out. Again, that's the thing, is if you got to have a value proposition that's high enough for the patient that they'll do it. And we were talking last night about, so what was the difference between the Zune, which did practically everything that the iPod did, and the iPod? It was a subtle difference. The biggest difference was integration with the platform. That was the biggest difference, is that it was integrated vertically between, a digitized platform for free and low-cost music. And so it was the digitization of the data and the economic value proposition of all the music I can eat.
So you've talked about the fact that this free flow of information is probably the critical element to make all of this work successfully. So how do we make sure that everyone is involved, and potentially are there any current or anticipated data blocking challenges?
Well, okay, I'll take that one first. I think, are there people out there that have nefarious intentions? I think that's probably true. That's, I think it was Leslie referenced that there's some percentage of fraud that is always occurring. Is data blocking as an intentional and malicious act the reason we don't have greater interoperability today? I don't necessarily think that's the case. And I think, again, it gets back to, in the privacy of the boardroom, have we given them enough value at a low enough cost? And I think we're getting there. That's exactly what all of us up here are trying to do, and everyone in the room as well. So I think yes, there are probably cases that need to be dealt with, just as any case of fraud or malicious intent needs to be dealt with. But by and large, the steps that we're taking, I think will help to make it less of an issue over time, because there will just be less and less of a legitimate reason, if you will, to not participate.
I agree with Dave's comments, and I would take it even one step further back. What are the incentives for data blocking? Let's go to a root cause analysis on that. Why would an organization, whether it's a health system or a vendor, it really doesn't matter. Why would anyone want to do that? And so I think that's where we have to attack things systemically and say the incentives need to be fundamentally changed so there's an incentive for data sharing, not data blocking.
And 21st Century Cures is a pretty good little incentive. Or disincentive, as the case may be. So the interesting question I have, or I don't know how interesting it is a question I have, that the places where data ends up in healthcare is, a lot of times the patient doesn't even know where this data is. And they certainly don't know. They don't know that HIEs exist, for example, for the most part. So the data ends up in an HIE. They don't know to what extent the data is going to the payer and is present there. So what will be interesting to me is when data is curated and managed by an entity, are all the entities that hold data, are they all going to be subject to the potential data blocking fine? Because I think there's been a focus on the vendors first, and then there's a focus on the provider organizations, but there are going to be other holders of data, and they are all going to need to be able to make that data available if they aggregate it and enrichen it. If a patient's data should be portable from a provider organization, it should be portable from a payer too, which is going to be a huge change in the mindset of U.S. healthcare.
That actually touches on the next question that I was going to ask for the panel, which is how can the payers help us in supporting meaningful interoperable exchange?
One thing I'd note is that I think there is so much good work being done around query-based exchange. Their query-based exchange is farther along than anything else at this point. And FHIR is just another example of query-based exchange. So people talk about FHIR and XCA as two different things. They are, but they're real similar in that they're both, I'm going for something that I want to go get. I'm going to go get it. So that query-based exchange activity, to the extent payers can rely on query-based exchange to get the data that they need, they can reduce the costs of implementing interfaces. The costs of implementing interfaces arise from difference. If things are the same, they're cheap. And the vendors do a good job of optimizing around sameness. If you do different things in all 50 different states, or in one state, different things for every payer, it's incredibly costly. That's what drives the costs, not greedy vendors.
We see that kind of variability state by state, and a lot of the national carriers, of course, want a single solution to a state-by-state problem, but yet that's not where these problems are often attacked. It's at a state-by-state basis. So I would say, yes, they certainly have their own data needs to inform their own care management processes, but I think where there's some exciting work occurring across the country is around the reporting of electronic clinical quality measures that would be based on both claims data as well as clinical data. That's where some of these incentives that we've been talking about for value-based care, they take on a lot more meaning when those measures are based on both clinical as well as claims-based data. So everyone, when it's time to pay for interoperability, everyone points to someone else. Everybody wants it, but nobody wants to pay for it. But I think, again, kind of the fair share concept, value given versus value received.
Yeah, well, it always comes back to carrot and stick, and the carrots tend to make people look at it more positively, but the stick is sometimes necessary. So, Dave, did you want to make a comment?
No, I think I would agree with everything that was said here. One piece just to reiterate that I think was sort of alluded to, but just to be very clear, one of the roles that I think payers have is to incentivize, please. But by the same token, at the same time, as Michael was saying, everybody wants somebody else to pay for it. Payers will probably be willing to pay up to a point, if they're in fact getting better outcomes, and which ultimately are lower costs to them. And so again, it all rolls together. You can't separate the one question easily from the others, because it all is, how do we advance all of these things sort of simultaneously, and it's going to happen fairly organically, like with any ecosystem. But the payers seeing value, which I think they're starting to see. I think they're seeing, if not immediate value right now, they see their way to there being value, and I think we'll start to see a shift in payer participation here over the next year or two. And once that starts to happen, they will be in more of a position to drive incentives.
So we're obviously in a very dynamic world and situation, and thinking specifically of the organization that you did or do represent, what's the future path for that organization? How will it relate to that broader ecosystem that you just referred to, Dave?
Well, I think the role for CareQuality really is to be an enabler of the change that everyone is going to have to affect. As I was just alluding to, this isn't something that CareQuality can solve. That would be lovely, I suppose, in a way, although a huge responsibility for me. But fortunately, along those lines, it's simply not possible for CareQuality or CommonWell or the eHealth Exchange or MiHIN or HL7 or ONC to solve this problem. Everyone needs to work together. That said, what we specifically see as the role for CareQuality is to take that trust framework that I alluded to, that allows for the connectivity between these various entities, and just expand its use, put it out there, allow others to incorporate it. Scott mentioned that FHIR-based exchange is really very similar in some fundamentals to query-based document exchange. So we're in the process of looking right now at what is the appropriate role for CareQuality and the CareQuality Trust Framework to play in a FHIR-based exchange ecosystem. And looking again at just other challenges that we need to solve in healthcare. And the first step, obviously, is, okay, what is the actual role for the CareQuality Trust Framework? Where does it make sense to have this sort of concept of sign one contract, do one implementation, and then being able to connect universally? It fits well in some models, and it isn't as important in some others. And so identifying exactly what the right use cases are for us to go into, but things like allowing alerts to occur between hubs about a patient with a subscription model behind that, image exchange, all of these things are on our roadmap, but to a certain extent it's about responding to what our constituent network services and programs are all doing and what their needs are. So obviously there's a bit of a balance there between leading and following.
Sure. Okay.
Yeah, so CommonWell from the beginning imagined itself as a framework for an ecosystem, not just a place where a few services were put up. So I think CommonWell's future is really around allowing members to provide ancillary services that leverage the core services that are part of CommonWell to bring new capabilities to bear. One such potential ancillary service that might be offered would be a MiHIN service offered for interstate immunizations communication as a possibility. Conversation underway with MiHIN over the course of the last year. So the potential of being able to use the core services, Commonwealth's core services around identity and record location, and connect them to another service that does something entirely different. That is offered by a member of the Alliance. And it's possible for the Alliance to do that because it's a consortium of HIT companies that agree to promote a use case, and then any one of the members could provide that service to the other members and to the public at large. So I think that's the big shift for CommonWell over time, besides just sticking to the knitting of just lighting up on-ramps and improving the quality of data. And so that, I think, is a shared, I would agree, I think we all share this problem, which is that the 2015 edition gives you a baseline of expectations around how the data should be formatted and codified. But conformance even to that is really pretty spotty currently. The truth will be in the pudding, like what happens next year when those 2015 edition stuff comes out and the new testing tool is applied against that, will that mean everything's better? I hope so. But it still won't be rich enough because the actual required data elements are not what they want. They want the story of the patient. So there's a ton of work that we all have to do to get the quality of the data from all of the endpoints brought up, and how interesting it is, what that data is, what's in that payload.
Thank you. A couple of comments. One is on the eHealth Exchange front. eHealth Exchange is preparing to become a CareQuality implementer. So this would allow one more level of interoperability amongst these various initiatives. So this was a significant breakthrough that occurred in December when these two organizations signed an interoperability exchange agreement. It significantly advanced the cause of interoperability in this country. Likewise, a lot of people have said, well, I don't know which plug to plug into. Do I plug into eHealth Exchange, CareQuality, CommonWell, and so forth? I think we're getting much closer to the point where we're taking the decision away. You know, it just says it's okay. Whichever makes the most sense for you to plug into, we're going to do the hard work on the backside to make sure that you haven't done some kind of limited impact on the other side of that. We're going to figure out for the other types of use cases how to make those connection points work. And I'll also just close by on this one to say Sequoia recognizes the same things we've been talking about here, and Genevieve in her remarks. There are a number of tiger teams and task forces and so forth looking at things like provider directories and patient matching and that sort of thing. And something that's just always impressed me about Sequoia is its role as a neutral convener, you know, to get people who recognize a problem, can bring their bright minds together and come up with some creative solutions around that. So while we have some specific initiatives that get rolled out, we also hope to be, you know, continue to be that place where people can come together and create something good.
Excellent, thanks. Well, we had one more question, but I'm going to skip that one because I think all of you out here may have questions or insights that you're looking to gather from our excellent panel. So who has the first question? See someone up here in the front. Yep.
Okay. Oh, terrific set of comments. Thank you. So you've brought up many times a sort of idea of costs being weighed against the investment, or benefits being weighed against the investment. So I'm curious what specifically you're doing to bring down the investment cost, and not just the direct cost of participation, but sort of the fully loaded cost. And 2 years from now, if the cost today is X, do you think we'll be at 80% X, 50% X? What does the trajectory look like?
Well, I think Scott made a really good point earlier about how having the sameness, I forget his exact words, they were really good, but something along the lines of sameness is cheap. What we're trying to provide, actually I think across all of us up here, is that sameness, some standardization, not only in the actual technical standards that are used, but in legal terms, so that you don't have to reinvent the wheel every time you need to make one of these connections. That's really one of the biggest steps in lowering the cost, and it's always going to be an ongoing effort because there always is one more thing to standardize as you keep peeling away layers of the onion. I don't know about specific percentages. I don't know if you guys have any thoughts there.
Yeah, I mean, again, I totally agree with what you're saying. It's sameness is big. The other thing that's big is to the extent you can behave like a true network. So where one connection connects you to all, then it's, so here are the hard ones. So the margins in long-term care, in post-acute, are so thin. So that one's scary. But there's also, I talked to a company recently who's in the school nurse EHR business. There's a crap load of school nurses out there. And you know what the national ratio of patients to school nurses is? It's 4,000. That's the ratio of school nurses to students. And the number of patients that they see that they are actually their care provider, their only care provider, like Medicaid patients frequently, their primary care provider is their school nurse. If you're going to light up those nodes, it's going to have to be really, really cheap. So, because the schools don't have two dimes to rub together, and their funding is going down, not up. And so for us to assume we're going to connect all of the dots in healthcare, it's going to have to be a true network. So it's going to have to be the kind of thing that you can connect to, and the network knows it has some level of intelligence. That's infrastructure, and that's what's required. So someone has to fund that infrastructure. I think the idea is to try and do that with as many players, so the cost of funding that infrastructure is low to all participants. So the more players are involved in the funding of an infrastructure model, the better that works.
I would only add that the most encouraging thing about these two initiatives are the significant engagement of the EHR vendors. And so, there's one thing to have the infrastructure costs as low as possible, but a lot of that cost is going to be on who your EHR vendor is. So to have them at the table of these two guys, that's massive, and bringing hope to be able to bring that cost down.
And to piggyback on the including everyone in it, you have to remember the scope and the breadth that we're talking about, because we can make a huge impact on health initiatives, person-centered quality, if we can make sure that schools, long-term care, home health are all connected in. So it's not just the big vendors. So important points. Other questions?
I think we have time for one more question for this absolutely fantastic panel. So
Yeah, we don't want to stand between you and lunch. So, yeah, got a question here. Coming.
Here she comes.
Can do it. Thank you. I'm with iAssay. My name is Lonnie Edelman. We're developing a new handheld for testing people in their homes. Nurse comes in and tests the patient. So what can you tell me about what we should be thinking about with respect to what we need to do on the EHR side? I mean, right now we take data, we squirt it out through Bluetooth with one partner that we have, and they take care of everything else, HealthNet Connect. In general, what should we be thinking about?
So the device space is interesting because it has connection points in a lot of different spots, but principally the EHR suppliers are making those connections directly to the EHR through infrastructure that they put up. So I think that now increasingly, I think there is the notion of these data coming through, a portal that a patient is engaged with. So if a patient is able to provide a conduit by their involvement and in their selection of an app that has a capability and a connection point. So I think that is the more viral kind of model, as opposed to going out and knocking on the doors at the 10 big EHR vendors. That would be my thought. It's those viral app store participants that are the easier road in. I think at some level.
And that I think there's definitely merit to that, and looking at what the role the patient can play. It sounds like you are not necessarily immediately engaged with the patient so much as a nurse from a workflow standpoint. So that there may be a need also, or a desire anyway, over time to migrate towards directly integrating with the EHRs or PHRs, wherever the patient's sort of record home, if you will, is going to be. Along those lines, being on top of, within reason, some of the developments with HL7 Fire and the APIs of the various vendors and their offerings. Now, again, it's not ideal to have to go, as Scott was saying, door to door to 10 different vendors, but that's exactly the sort of challenge that CareQuality is looking to address in saying, okay, how can we standardize that so that we have a definition that all of the vendors can meet, as well as some operational structures around how they can be aware of these various apps that will ultimately allow them to plug in and connect to one another. realistically, that's not going to happen next month. But over the next couple of years, I think that's going to start to be more of a reality.
Michael, you get the last word.
Yeah, Greg, I don't have anything to add on the question, but I'll close my comments how I began, and that's really to acknowledge the work that Tim and Jeff and all of their colleagues have done in Michigan. In my role with Sequoia, I get to see a lot of good people doing good work, and I will tell you, I'll put Michigan at the top of the list. And I know that this is occurring not just at an organizational level, but what you've done to create this ecosystem of supportive interoperability, to have a lieutenant governor come up and say how supportive he is and the administration is for the goals and aspirations. I just want, if you're not already, and I suspect you are, to be very proud of what you have accomplished, are accomplishing, and will accomplish in the future. It's very exciting to be on the ground with all of you for a couple of days here, and just hats off to all your fine work.
Excellent. Thank you. Please help join me in thanking our panelists.